you swallow a pill. It's a standard 200 milligram tablet of ibuprofen, and your headache is absolutely pounding. You probably expect it to just go straight to your head and turn off the pain, right? Well, picture this. From the moment you swallow, imagine that ibuprofen as a glowing teal molecule. We're going to follow its entire tablet-to-toilet journey. And trust me, it's not a simple ride.
Because here's what most people, honestly, even a lot of students, don't really think about. That pill has to survive an absolute war just to reach your bloodstream. Think of our glowing molecule as an action hero. It gets dropped into a vat of acid, dissolved, chemically attacked, filtered, and actively destroyed, all before you even feel a hint of it working. Pharmacokinetics is the science of that entire perilous journey. And once you actually understand it, well, every single dosing decision starts making total sense.
Think of today's explainer like tracking a package. Here's our roadmap. 1. The ADME framework. 2. Absorption. 3. Distribution. 4. Metabolism. 5. Excretion. And 6. A clinical summary. Starting with Section 1, the ADME framework. In pharmacokinetics, we're focused entirely on answering one fundamental question. What does the body actually do to the drug?
The body's reaction happens in 4 distinct stages that spell out the acronym ADME. Absorption, getting the drug into the bloodstream; distribution, spreading it around; metabolism, breaking it down; and excretion, removing it. If you ever find yourself blanking on these 4 stages, just remember this simple cheat code. A drug must exit. Lock that in. A drug must exit. So let's just go stage by stage. Section 2, absorption, crossing the wall. Our dissolved ibuprofen is just sitting there in the stomach and the gut, but it's totally useless there. It faces its first major gauntlet, which is crossing the gut wall via passive diffusion, just to get into the blood. Now, the route of administration completely changes the game here. Ibuprofen is slightly lipophilic, meaning it likes fat, so it crosses the cell membranes of the gut reasonably well. But highly hydrophilic, or water-loving drugs, like the antibiotic gentamicin, they have terrible oral absorption. They literally just bounce right off the gut wall. That's exactly why gentamicin has to be given IV, where absorption is immediate and 100% complete. Alternatively, sublingual routes, like a GTN spray under the tongue, offer incredibly fast absorption directly into systemic veins. But let's stick with our oral ibuprofen. It crossed the gut wall and made it into the portal vein. Massive success, right? Well, not quite yet. Before it reaches the rest of your body, the portal vein takes it straight to the liver. The liver sees this foreign chemical and ambushes it. We call this the first pass effect. I actually like to call it the liver's tax. The liver takes its cut before releasing the rest into your bloodstream. This explains why an oral dose of morphine has to be significantly higher than an IV dose. The liver essentially destroys a massive chunk of that oral dose before it ever gets a chance to act.
And this brilliantly illustrates our next core concept, bioavailability, which is represented by the letter F. This is the actual fraction of your original dose that survives the liver's tax and reaches systemic circulation unchanged. Oral ibuprofen actually has great bioavailability, hovering around 80 to 90%. But remember that GTN spray we just talked about? If you swallow GTN orally, its bioavailability drops to about 1%. The liver's first pass effect on oral GTN is just so extreme that the drug becomes essentially useless. That's why wildly different dosing strategies, like a sublingual spray, are absolutely required. It's not a mistake on the prescription, it's pharmacokinetics.
Moving to Section 3, distribution, spreading the drug. Our glowing ibuprofen has survived the liver, but to actually cure your headache, it needs to leave the blood and spread out into your tissues.
Before it can cross into those tissues, though, it faces a hitchhiker problem in the bloodstream: plasma protein binding. See, many drugs bind tightly to proteins like albumin in the blood. Ibuprofen is actually 99% protein bound. Only the 1% that remains free can slip into tissues and actually do the work. Which brings us to the volume of distribution, or VD. The absolute easiest way to remember this is big VD equals vanished, small VD equals stays. And here is a vital clinical pearl for you. In patients with hypoalbuminemia, meaning low albumin levels from malnutrition or liver disease, there are fewer proteins for the drug to bind to. This means you get a lot more free drug floating around, which can quickly lead to toxic effects at completely normal doses, especially with highly bound drugs like the blood thinner warfarin.
Let's compare 2 extremes to make this concrete. Warfarin has a very small VD. It stays mostly in the blood. But a drug like the anti-malarial chloroquine, it has a massive VD of thousands of liters. It has completely vanished from the blood and hidden deeply inside your tissues. Clinically, this is critical to understand. If a patient overdoses on a drug with a huge VD like chloroquine, it is a total nightmare to manage. You can't just dialyze them because the drug isn't in the blood for the dialysis machine to clean. It's buried deep in the tissues. Section 4. Metabolism, the liver's ambush. The body eventually needs to neutralize the drug. The liver handles this in two distinct phases. Just remember the phrase functionalize to fare well. Phase 1 adds a reactive functional group to the drug, and Phase 2 attaches a large water-soluble molecule to say farewell, priming it to be flushed away. Doing the heavy lifting of this metabolism is the liver's highly specialized army, the cytochrome P450 system. Now, CYP3A4 is the absolute heavy lifter here. It metabolizes roughly 50% of all drugs on the market, including statins and a ton of antibiotics. Meanwhile, CYP2C9 is the exact enzyme actively breaking down our glowing ibuprofen molecule right now. Now, here's a pretty fascinating twist. Sometimes we actually use the liver's ambush to our advantage by administering a prodrug. A prodrug is essentially an intentionally inactive compound. The rule of thumb here is prodrugs need processing to perform. The antiplatelet medication clopidogrel is a perfect example of this. It's totally inactive until the liver enzyme CYP2C19 activates it. But if a patient genetically has poor CYP2C19 metabolism, the drug never actually turns on. This is precisely why some patients tragically suffer stent thrombosis, a blood clot in their heart stent, despite religiously taking their clopidogrel.
Because these enzymes are so crucial, mixing medications becomes a dangerous minefield. Other drugs can either induce or inhibit this enzyme army. Let me give you the absolute best mnemonic to keep this straight. Rifampicin revs, erythromycin jams. The antibiotic rifampicin revs up the enzymes, making them break down your target drug way too fast, which leads to treatment failure. Erythromycin, on the other hand, jams the enzymes, slowing them down. If you jam the breakdown of a statin, for instance, it accumulates in the blood, leading to a really high risk of muscle toxicity.
Section 5. Excretion, the final exit. We now guide our water-soluble molecule down to the body's great filter, the kidneys.
The kidneys have three main mechanisms to get this job done: glomerular filtration, active tubular secretion, and passive tubular reabsorption. But here's a brilliant clinical trick for you. Reabsorption means the drug diffuses back into the blood from the urine, but we can actually manipulate urine pH to trap certain drugs and physically stop them from being reabsorbed. For example, if a patient overdoses on aspirin, which is highly acidic, we can intentionally make their urine more alkaline. This chemically traps the acidic aspirin right in the kidney tubules, forcing it to be flushed straight out of the body. As we wrap up talking about clearing drugs, I want to burn this magic number right into your memory: 4 to 5. This is the absolute clinical workhorse number for pharmacokinetics when we talk about a drug's half-life, which is simply the time it takes for the drug's concentration in your blood to drop by exactly half. So why 4 to 5? Because the rule is it takes 4 to 5 half-lives to reach a steady state for full therapeutic effect, and it takes 4 to 5 half-lives to fully clear a drug from your system. Let's compare two extremes here. Warfarin has a half-life of roughly 40 hours. Multiply that by 5, and it takes almost 5 days to completely clear the body. But the antiarrhythmic drug amiodarone, it has a massive half-life of 40 to 55 days. Multiply that by 5, and it takes months to clear. If you stop amiodarone in June, that drug is quite literally still inside your patient in August. And finally, Section 6, our clinical summary. We followed the journey from start to finish. Every single stage of ADME shapes the famous concentration time curve. The rising slope is absorption, the falling slope is metabolism and excretion. And that shaded area right in the middle, that's your therapeutic window. Your entire goal as a prescriber is to keep the drug hovering beautifully in that window, above the minimum effective concentration so it actually works, but right below the toxicity line so you don't harm the patient. This rapid-fire ADME cheat sheet condenses everything we just covered, from bypassing the first-pass effect in absorption, to the dialysis dangers of a huge volume of distribution, to the CYP enzyme minefield, and finally, the 4 to 5 half-lives rule. Next time you're making dosing decisions, this is the exact framework you need to recall. And that concludes our glowing ibuprofen's wild ride from tablet to toilet. Understanding ADME isn't just academic theory. It's the absolute foundation of keeping your patients safe. So I have to ask you, which stage of ADME do you find most confusing? Think about it and let that guide your future study. In our next explainer, we'll flip the script entirely and dive into pharmacodynamics, which is what the drug actually does to the body once it survives this incredible journey. Stay curious, and I'll catch you in the next one.